So without further ado, we've got Dr. Peter McNaughton, Paediatric Immunologist and Allergist, who also works within the bone marrow transplant team doing transplants for patients with inborn errors of immunity. Dr. McNaughton has an interest in the diagnosis of monogenic immunity, inborn errors of immunity, and a research interest in implementing mainstream genomic testing for these patients. Thank you.
Morning, everyone. Thanks for having me. Clearly, I'm the only one who responded with the headshot. Next time, I'll know to ignore that part of the request. Thanks to organisers for asking me to talk about a very difficult topic. HLH. My personal view on HLH is that I'm not an expert in HLH, and I think anyone who thinks they're an expert probably doesn't know enough about HLH. And I think anyone who's confident in treating HLH probably hasn't seen enough HLH. So I have a very healthy respect for how difficult it is to diagnose and manage HLH. I'm going to try and give you a quick overview, which is quite difficult. But I think that's why we're talking about it at a transplant meeting, an ID transplant meeting, is that probably most of these cases are going to get discussed with the ID physician at some point. As part of the diagnostic criteria is fever and sepsis-like presentation, often prolonged fever without a clear cause. So you might be one of the first physicians who gets asked about this, and it can be really difficult to recognise. So I think it's very important for ID physicians to consider HLH. So the classic, we kind of talked about sepsis-like presentation with diagnostic criteria, including fever, cytopenias, hepatosplenomegaly. Neurological presentations are very common. So can be up to a third of cases presenting with neurological symptoms. I think it gets forgotten because it's not part of your criteria. But it is certainly something that I think probably presenting more than we recognise. The classic, laboratory findings of elevated ferritin, triglycerides, LDH, and low fibrinogen. Hemophagocytosis, which is very non-specific finding, and then other markers that we discussed, like cellular CD25, which aren't available everywhere. So I'm going to talk a little bit about kind of an approach to this. These are the criteria that you can kind of learn out of a textbook and then see some HLH and forget about. Because I think if you did a survey about any unwell patient in ICU, they'd probably meet several of these criteria. To meet the diagnostic criteria, you need 5 out of 8 of these. You often can't get all of these in a reasonable time frame, so you can't really use that whole 5 out of 8. And many people will meet these criteria without having HLH. So yes, useful, need to know it, but it's not going to help you identify all cases of HLH. And if you use this criteria to initiate treatment for HLH, you'll be over-treating. So this is from a recent publication, which has some really, really beautiful pictures in it for an immunologist to kind of spend some time on. But I'll just take some time to talk about the pathophysiology. And this is obviously a gross oversimplification of a very complex process. But I think it captures a lot of the really important parts and helps explain some of the symptoms. It also helps explain some of the things that contribute, risk factors, and also the treatment. So we start with a cell that can be infected or can be kind of proliferating and causing an immune response for other reasons, like malignancy, for example. But often it'll be secondary to an infection, even in cases of primary HLH. It'll often take an infectious trigger to trigger your primary HLH. That causes activation of your innate immune system, macrophages particularly, which will then secrete lots and lots of cytokines. As part of that immune response, you have response of your adaptive immune system, your CD8 cells, which come in and help to kill the cells. And then NK cells, which also help to kill the cells, but also help to regulate your CD8 cells so that they don't over-proliferate. And so this all has to be kind of pretty balanced. So you want a nice response that gets rid of the problem that started with, but doesn't cause too much inflammation and immune activation that you cause damage to organs but from your immune system, which is worse than what you started with the infection. So when that's all working well, kind of upregulates appropriately and then downregulates appropriately, and then you get back to square one. You can have problems with this whole process. If the infection's not cleared for whatever reason, this will continue and can amplify. So you have a positive feedback loop and it doesn't switch off. Your macrophages can over-secrete these inflammatory cytokines. CD8 cells and NK cells can have defective killing, where they can't kill the infected cell or they can't get rid of the activated innate adaptive immune system, and so it just continues on. Now, this is where the familial HLHs operate, because the NK cells and the CD8 cells can't lyse cells. So they can't kill the infection and they can't switch themselves off. And so the primary HLH all are to do with these degranulation of CD8 and NK cells, and getting these kind of these granules to the surface of the immune cell and degranulating so they can kill both the target cell but also downregulate the immune response. The most common of these is perforin, and perforin is relatively easy assay to get on a flow-based assay, and most hospitals probably would have perforin. So there are some hospitals who anyone who has HLH would do a perforin flow as an initial screening test. There are other parts of this process, and we mentioned UNC13D is one of the, one of this pathway, and that's what our girl that we talked about with the CNS HLH lacked that part. So she couldn't effectively switch off inflammation that had been activated. So Tiani alluded to, we can do a functional test to see that degranulation process. That is a send-away test for us, available in Melbourne. I'm not sure where else is doing that test, but it's affected heavily by steroids. And so a lot of these patients will have been treated with steroids for their unknown fevers or inflammatory process, so you can't do the test. It's also, needs to be sent and done within 24 hours with a travel control, so it's a bit of a finicky test to organise, and it can be affected if you're very unwell, which just universally these children are. And as Tiani also alluded to, they can do genetic testing for these kind of parts of the familial HLH. It's not affected by steroids, but takes a long time. So you can't really wait, in most cases of HLH, for 6 to 8 weeks to make your diagnosis and initiate treatment. So let's talk about the easy bit. When you've got a diagnosis of confirmed primary HLH, you need to treat as early as you can and treat aggressively and work up for a stem cell transplant to provide some cells that have those molecules to allow them to have effective regulation of inflammation. Ideally, you want them to be in remission from their HLH before you go to transplant, but that's not an absolute requirement, and often you won't be able to get them into complete remission. So you want them in the best remission possible on the least immunosuppression possible before you move to transplant. The treatment protocols, really based on these HLH 94 and 2004 protocols, and they're all based on high-dose steroids. And then etoposide is an agent which particularly targets proliferating and activated macrophages. There's been lots and lots of studies into other modulation as we have more agents available to target individual cytokines. They've pretty much all been tried in HLH management, and they've all got potential roles to target really this cytokine storm, which is either IL-1 or downstream of interferon, or amropalimab, which actually directly targets the interferon itself, or alemtuzumab, which basically gets rid of all of your CD8 and NK cells to stop this proliferation. Obviously has other risks as well. Now, I have seen infants with primary HLH who have presented early who need all of these medications and still doesn't switch off their HLH. So it can be utterly, really, really difficult to treat. And obviously, when you're targeting, steroids, topicide, multiple different cytokines, your risk of from immune suppression escalates. And once you get rid of your, put in an antibody against your CD8 cells, your risk of viral reactivation becomes extreme as well. So it becomes a very, very difficult situation. And this is the easy case where you know what you're actually treating. So that's it. You understand how it presents, the pathophysiology and the treatment. So let's move on. But it's not that simple, unfortunately. So as I alluded to before, many patients will meet all or many of the criteria and not have HLH, and some or many patients will have HLH and not meet the criteria. There's a high mortality rate, which you want to treat early and aggressively, and all the treatments are very toxic treatments. So how do you treat aggressively and early with toxic medications when you're not sure if they've got HLH or not? And that's where I don't have any great answers for you. Sorry, but I'm going to talk about some things to consider, and maybe I think that probably having ID physicians at least aware and thinking about it is a part of the process of identifying this early and getting better initiation of treatment. This whole primary-secondary divide, which makes you feel really nice putting them into a category as well, I think is not quite so straightforward either. So, you've got these familial HLH genes, which are your primary, but anything that causes you to have less effective clearance of your infection can predispose you to having HLH. So, patients who have innate disorders in the innate immunity don't have a familial HLH, but they can't clear virus, for example. So we've had a few patients who've had a specific viral susceptibility, and they just can't get rid of it. So they get very inflamed and at risk of HLH because they can't get rid of the virus. So the rest of it works, but the virus is still there. Similarly with malignancy. So if the malignancy is hanging around, causing this response, even if your immune system is working, if you have a less profound inflammatory immune dysregulation disorder where you overproduce certain cytokines or you over-respond to interferon, for example, you're more primed to get HLH. Things like CGD, which you would think would be completely unrelated, where you have extra inflammation from defective killing from your neutrophils, can get HLH. So I think that this divide of primary and secondary, simple if you've got familial HLH, but what about other disorders of immune regulation and or innate immunity, which predispose you to having HLH? And so there I'm talking about the kind of endogenous components. And then I think probably from an ID point of view, you might think more about the exogenous components. So difficult to treat infections that predispose you. And you may present without HLH with one of these problems and then later develop HLH, which makes it quite complicated as well. And then you get the atypical HLHs, so the late onset primary HLHs. So these primary HLHs, if they present with all the criteria in early infancy, figure it out. But they think that around up to between 5 and 10% of HLH that presents over 13 is actually got an underlying diagnosis of primary HLH. And the oldest patient I saw presenting in the literature was, I think, 54. And so I don't think that our adult colleagues can be completely confident in labeling it as a secondary HLH. And even up to around about 5 to 10% of cases may actually be primary HLH. And they may not be investigated, which is okay if you're treating and getting it under control. But if you've got primary HLH, you still remain at risk. So the ultimate treatment is a transplant. So if you end up going to transplant anyway, then maybe it doesn't matter, but probably not going to transplant your adult HLH patients before their second episode. If you can't get an underlying diagnosis and it's a secondary, I think everyone should definitely, you may not investigate everyone who's an adult as a primary HLH in their first presentation, but anyone who has a second presentation should be aggressively investigated. I think sometimes it's impossible to avoid 2 lots of HLH, but we shouldn't be letting people have a 3rd lot of HLH before we think we have them. And then, as Tiani alluded to, this isolated organ involvement, CNS, and liver, and they estimate around 3% of pediatric acute liver failures due to isolated liver HLH. And that may develop systemic features of HLH, but you may present, and we've certainly had a patient in this hospital who's had liver failure, acute liver failure from HLH without all the systemic markers. And so that's terrifying. How do you go about investigating for HLH in single organ without any of the criteria? And then I guess just to also mention, transplant meeting, that it's not an uncommon thing to happen after transplant. So a few studies estimating anywhere between around 5 and 10% of allo transplants developing post stem cell transplant HLH. So that's quite a lot, really. And are we under recognizing it? And of course, post transplant, the criteria aren't going to apply. It's going to be cytopenic anyway. Probably got fevers for whatever number of reasons. Probably got liver derangement for whatever number of reasons. How do you identify a post-transplant HLH? It's a very, very difficult thing. And then also mention, I noticed that there's some talks on CAR T, and with the massive cell lysis and cytokine storms induced by CAR T cell therapy can also induce HLH as well. So around 5% of cases, and as we're using that more and more often, we're going to see more of this. And are we going to be able to recognize it? So I don't have any answers to these, but I have a few questions that might help at your site. And so first question is, who manages HLH at your site? And I think it's really, really challenging because ID is probably going to be called, once you think there might be HLH, they might call a rheumatologist, they might call an immunologist, they might call a oncologist, and there might be differing opinions about whether they have HLH or not and whether to treat or not. So is there a defined pathway of referring suspected cases, and how do you talk about it? And we've certainly had emerge sometimes someone has a lower threshold to consider HLH, might refer to somebody and people say, oh, I don't think it is. And then they'll go and talk to someone else who may be more on their kind of. So there's a bit of splitting and a bit of shopping for opinions that can occur if you don't have a defined pathway. What happens if there's disagreement? How do you pull a trigger on treatment if people can't agree if they've got it or not? I think that's something it's good to consider before you're in the situation. And is the team that has to decide about escalation of therapy involved early? So we've certainly had cases where people have a discussion, people decide, oh yeah, they've got some kind of HLH-like inflammatory thing, let's give them some steroids. It doesn't get better, add a bit of anakinra or whatever the flavor of the month is, and then it's not getting better. And then down the track, they then ask someone, oh, should we be doing HLH 2004 and a bone marrow transplant? And you can get no diagnostic information because you're partially treated. So I have a very strong feeling that whoever is going to have to decide on therapies like etoposide and Campath, for example, should be consulted early before other therapies are given. There should be a pathway to that. How you enforce that or enable that, I think, is something that each kind of centre needs to think about. What investigations can you do at your site, and what for primary HLH and some of these other markers, and how long does it take to get them back? That's a good thing to know. It'll be different everywhere. And what are the therapies? What's the pathway? You said that once you've got through kind of Dex and etoposide, you can kind of take your pick. And how do you take your pick? And how do you talk to your medication committee about which one you want to use and what's the pathway for that? And so, this is a very high mortality condition. What can you do at your local site to improve the outcome for these patients? And that's an open question that I don't have the answer to, but I had a few things that I thought about being involved in a number of these cases.
So thanks, Peter, for that talk. Wondering if there are any other questions from the floor?